Another sort of big picture item has to do with CR and healthcare variations in spending, the Dartmouth evidence. And here I'm going to talk about very recent research that we've done where we looked at variations, but with the difference from Dartmouth. Dartmouth is exclusively about Medicare. And we are completing a study now which essentially looked at variation in treatment, both in utilization and spending, for heart disease, and we compared private plans with Medicare. And virtually all the variation goes away in the private sector. So this basis for healthcare variations as a motivator for waste, and therefore as a motivator for CR, is a little bit misguided, I think, if this evidence turns out to be generalizable. If it's not generalizable, if it's just true for our studies, it's not so misleading. But if this turns, which we would have strong priors about, certainly economists would have strong priors about the private sector having larger incentives to reduce cost inefficiencies. Why? Because someone can earn a better living if they do so. No one at CMS earns a better living by reducing Medicare variations. So the question is that a public phenomenon? And it appears in heart disease it is. That variations virtually disappear in utilization, for example, number of hospital days, hospitalization, and things like that, are very, very similar across regions in the US, even though they vary greatly in the Medicare program. And that we attribute to essentially the stronger incentives for, you have residual claimants, you have profits in the private sector, so you can compete better on premiums if you reduce cost inefficiencies, or even better, you can earn more profits. Another finding of that study was that drugs, one type of medical product, have virtually no variation at all, and versus procedures which did have a little bit more variation. Meaning drugs, we compared Medicare before Part D, this is before 2006, with private plan drug spending. And that's really a private versus private comparison, if you want. It's not a public versus private comparison, so you shouldn't expect to find that much differences in cost inefficient variations. But for this industry, I think it's important to see whether that's true for the devices or not. If this is true for the devices, that basically I think there's a much larger scope for inefficient variations in the procedure area than it is in the medical product area, including drugs and devices. And that's something that's borne out in our data. But I think this motivation, CR is sort of motivated. We need to figure out what works best or not works best, and it's driven by the Dartmouth Atlas evidence, which I think is misleading, because implicit in that evidence is that is a public payer who doesn't control cost, or doesn't have the same incentives, I would say, to control costs as the private sector does. So let's sort of zone in a little bit. Suppose you're a medical product company or a medical device company, and you're living with CER. Now, what will be the implications of CER as currently discussed? And presumably the discussion has been, the implicit discussion has been that CER is going to improve health and lower spending. That's sort of the whole goal of this public program being generated, or this public evidence being generated. But little is understood, essentially, if we go away from the rhetoric and say that this is just going to concern effectiveness. Not the rhetoric, but that's the claim. Obviously, it will not. I mean, if you generate better evidence on something and something shows that it's working better than another thing, obviously that's going to affect behavior in the market or in the subsidized market. So the question is, how exactly? What's going to happen when we essentially infuse publicly generated or publicly funded evidence into either a private market or publicly subsidized markets such as Medicaid and Medicare? And that's sort of the paper that we've been dealing with CER.